Cryotherapy is a well-established treatment for prostate cancer that has not spread beyond the prostate area. It is a powerful method for destroying cancer through the natural process of freezing the tumor. Because this procedure does not involve radical surgery, toxic chemicals, or radiation, recovery is quick, and if necessary, the procedure can be repeated. Here, Dr. Cliff Vestal discusses the options for treating prostate cancer with one of his patients who meets the criteria for cryotherapy.
Mr. Deering, how you doing?
Good to see you, Dr. Watt.
Good to see you back. Well, I got some good news, if the nurse hasn't already told you, and that is that your cancer is contained in your prostate. The bone scan, the CAT scan, all of your studies are negative for spread of the disease. So I think we have a good prognosis.
Well, you know what my feeling was when your nurse called me while you were in Ireland and told me that all of the results of the other examinations that you made were negative, and so I could afford to wait 2 or 3 more days for you to finally get back home.
Well, I'm glad to be here, and I'm glad to give you your good news.
Well, thank you.
So now we just have to talk about what to do.
Right.
We apparently have a cancer that's contained in your prostate. It has not spread, and so we have a variety of issues for a man your age. How old are you again?
67.
67?
No, I beg your pardon, I'm 76.
I've aged too since I've been to Ireland with all those children.
I bet you have.
Uh-huh. Anyway, for a man who's 76, we got several options for you that are available to eradicate the disease. And what we want to talk about today is basically what those options are and the risk and benefits of each and every one of those options. We know that a radical prostatectomy is probably out of the picture for someone who's 76 years of age. We kind of have a gentle cutoff at the age of 70. We do have the robotic prostatectomy, but even that we feel is a little too much for someone who's over the age of in their mid to late 70s. So what we have are 3 different things that we can offer you as far as curative therapy, and we have other things that we can offer you as kind of control issues. You can always watch the cancer if you'd like, but that just means
That's not an option.
Okay, well, good. I didn't think it would be. Hormone therapy, where we get a shot or we put an implant in once a year that will knock your male hormone down to 0, will control the cancer, but eventually it will escape that and we'll have to go on to some form of definitive therapy or to chemotherapy. So that's only a holding pattern, and it may last for 7 to 15 years. We don't know how long it'll last, but it does come with some side effects, including the hot flashes, bone loss, and whatnot. And again, it's not curative, it's just kind of a control measure. So I don't know if you're interested in that, but that would be one of the other options. And then we get to the curative, and those are radiation therapy, brachytherapy, and cryoablation of the prostate. All of them are minimally invasive. Indeed, the radiation therapy is just showing up at the radiation oncologist's office once a day for 5 days times 7 weeks and getting electron beam radiotherapy to the prostate gland. With your particular kind of cancer, that will probably give you about a 50% chance of long-term cure at 5 to 10 years. Now, that's something that we usually recommend to people who are a little bit debilitated, but because I know you play a lot of golf, bad golf that is.
That's right. But fun golf.
I think you're going to be around for quite a bit. So you have no other health issues. So I think curative therapy, which is a little bit higher in its propensity to cure, would probably be in order. And those other 2 issues, the same thing that I would tell my dad to do, would be either the brachytherapy, where we implant radioactive seeds, either palladium or iodine, into your prostate gland, and it's a day surgery, or the cryotherapy, where we freeze the gland and eradicate the disease by killing it with coldness. So those are the 2 options. So I want to talk about those here real quickly. Is that kind of what you have in mind?
Yes, I'm going to make my decision on one of those 2.
Okay, wonderful. But let's talk about the other first, and then we'll get into the risk and benefits of the cryoablation. With seeding, as I said, it's a day surgery. We put you to sleep, and we put the little seeds into your prostate gland, and we allow you to go home afterwards if you can void or urinate. The success rate is anywhere from 75 to 85% at 8 to 10 years, and it's good. And I think that you would be well served by it, but it has some complications, including urgency, frequency, damage to adjacent organs, and so we do treat it a little differently than we do with the external beam radiotherapy, in that the complications, if they're bad, can be really bad. If they're mild, it's like nothing happened to you. Impotence will occur, but it won't occur for several years after the radiation or the seed implantation. The other risks are strictures in the urethra, where it narrows down and scars down. And again, it gives you a good success rate, but it is radiation, and it does cause some other troubles. That, in comparison to cryoablation with your particular disease, which is the 10-year data comes out this year, and we know that the 9-year data now gives you about an 85% chance of no evidence of disease at 9 years, which should go on to be about the same with 10 years of data. It's basically placing probes into your prostate through your bottom, the taint, if you will. It taint the scrotum and it taint the anus. It's somewhere in between. We put those little probes in there under ultrasound guidance, so that we're actually watching your prostate gland visually, and then we freeze it to death, so to speak. It is similar to frostbite in that it kills cancer with the ice by a variety of different ways. So after we put those probes in, we freeze it, then we freeze it once again to make sure that we got everything, and it kills it by killing the cells and killing the vasculature, or the blood vessels that feed the cancer. It kills it that way as well, so it kind of suffocates it to death. Now, the complications from cryoablation are many, but are very low in risk. And those complications include urinary incontinence, or leakage of urine, which is less than 1%. The chance of a slough where the prostate dies and I have to go back in with the old rotor-rooter, if you will, is 4% or thereabouts. It just requires a secondary operation, and the incontinence rate shouldn't go up very high if that does indeed occur. The third thing is a fistula, or a hole between the prostate or the urethra and the rectum, and that's less than 1% as well. And when it occurs, it's a problem, but it usually can be solved through either wearing a catheter for a prolonged period of time or surgery.
Well, generally, what's the recovery period that I would experience?
Well, it can basically vary. It can be anywhere from a couple of weeks to a couple of months, and it just depends on the way you heal, if you will. One of the things that we will talk about is the little tube that we put in your tummy, because after we freeze your prostate gland, just like in frostbite, it swells up really large and blocks off your natural channel. So it may take a week or two to get that tube out. And so when you're able to void efficiently on your own, we pull the tube out, and it's a painless removal, but it will allow you to sleep all night because it'll drain into a bag.
I see.
The other thing that we need to talk about is the fact that we will follow you very carefully after the cryoablation. We'll get PSAs at 6 weeks, at 3 months, 6 months, 9 months, 12 months, and make sure that we have our thumb on the problem. Some of the other issues that we need to talk about as far as cryoablation would be swelling of the genitalia. The scrotum might swell up as big as a grapefruit, and that's normal. You just take it easy for a week or so and it goes away. Some burning and stinging may occur. Some blood may occur in the urethra for the first 6 weeks. There's a possibility that you'll develop frequency and urgency where you have to get to the bathroom, and you're going to know where all the McDonald's are between here and the house. Because you have to get there. It's going to be very similar to the women who have to go to the bathroom quite frequently, but that gets better over time, and by 3 to 4 months it's usually gone, and we do have medication that will help that. And those are essentially the issues. There's very little problems with bleeding. There may be some discomfort or pain, and you may feel like you're sitting on a golf ball instead of hitting one for a period of time, and we can correct that with medication as well, with anti-inflammatory drugs. But for the most part, I would say that 95% of the fellas who have this done are very happy. Many of them are out playing golf in 2 or 3 weeks, and it unfortunately doesn't improve your slice or your hole. So,
I don't think anything going to improve that.
Well, that's probably true, and I don't even play, and I'd have a wicked one if I would. Now, the surgery itself is going to take about an hour and 15 minutes as far as I'm concerned. You'll come in the hospital, you'll go to the operating room, you will have the surgery, you'll go to recovery. The nurses there will explain to you how to take care of the suprapubic tube. I'll give you a prescription today for your antibiotic and your pain pills that you'll take afterwards, and I'll also give you the little Bextra.
Will I not need to start any of that prior to surgery?
Oh, not really. The Bextra will, the little pack that I give you, you'll start the day before and you'll take it for 3 or 4 days afterwards. And that'll get rid of a lot of the swelling and a lot of the discomfort that you might have afterwards. Now you'll have those little areas in your bottom that are going to be sore for a few days, and so we do ask you to take something like a stool softener or Metamucil to make sure the bowel movements remain normal after the surgery. We don't want constipation at all. We want to make sure that the bowel movements are regular. We'll schedule this at your leisure. You'll hear from my scheduling person in the next day or two and come up with a date.
Well, Doctor,
if that's what you want to do.
As I mentioned, I would like to discuss this with my doctor, who I've known for many years. In fact, a great neighbor of mine now. And you're going to hear from me in the next couple of days as far as my decision.
Right. Great.
And at this point, I strongly feel that it will be the cryosurgery.
When you make your decision, just give us a call and we'll put it in the schedule. We'll do it down at our hospital.
I say, when you say I could hear from you within a couple of days after, how soon then would I go into surgery?
It just depends. You negotiate with the scheduler.
Okay.
It'll be a couple of weeks, 2 to 3 weeks before you get into surgery.
Doctor, as most men of my age at 76, is probably not a very serious problem to have to evaluate, but does this cease any sexual activity that I might
That's a good question, Mr. Deering. And if you are potent before surgery, you will be impotent afterwards. But there is hope. We know now that if you were potent prior to cryoablation, that after we freeze the gland, we damage the little nerves that go by the prostate, which allow you to have erections. If we give you a device after the surgery that'll pull blood into the penis and expand it and keep the elasticity, if you will, it allows the nerve to regenerate. And then in a year, 50 to 60% of the fellows will have a return of their function. So initially, you're going to have some erectile dysfunction. However, over time, if we actively exercise the penis, if you will, we will get return of function 50% of the time. And we think that's very exciting news, and we did it here in Texas.
Obviously, at my age, that's not supposed to be a very serious concern, but I do feel like I want the thought that I would not be totally incompetent.
Just like your golf game, if you work at it hard enough, it might actually work out. It might just work out.
Okay.
Exactly.
Okay.
So we'll try that 6 to 8 to 12 weeks afterwards and go with that.
Okay. Well, as I said, I'm almost certain would like to talk with Dr. Wombo, and I'll get back with you in the next day or two. But well, I'm very comfortable, and you've helped me tremendously in my decision, and I'm serious. I'm glad to be under someone's care such as you, and I appreciate you very much. Thank you very much, Doctor.
Okay, Mr. Deering, we'll see you in a few days.
Okay, thank you, sir. Thank you very much.
If you are a candidate for cryotherapy, we hope this program has helped you compare the procedure with your other options. No treatment is perfect, and the choice must be based on the unique needs of each individual patient. Your physician is your best guide and source of information. For more general information about cryotherapy, you can visit the patient site at www.prostatecancer.com or call 1-877-PCA-CRYO.